Doctor, thanks for an excellent presentation. Just what this conversation hoped to be, which is solid, reliable information. There is so much specious and spurious information available, some good on the internet, a lot of it is not good. What the Prostate Cancer Mission is about is finding the best people to give us the best information, and that's exactly what we heard. And what we are going to hear more of right now from Dr. Arthur Bud Burnett. He is the director of the Male Consultation Clinic at Johns Hopkins University. Dr. Burnett is an expert in the areas of voiding and erectile dysfunction. He is recognized for original discoveries of nitric oxide biochemical mechanisms in erectile tissue that paved the way for the clinical development of Viagra. This is certainly a key issue for any man and his spouse, erectile dysfunction. And here is the gentleman who is one of the acknowledged experts. Please welcome Dr. Bud Burnett.
Well, good morning, all. Thank you for that warm introduction. It's certainly a delight to be here. I feel honored. My tribute goes out to all of you because I think this is a very important event. I think that the intent here to improve awareness about prostate cancer, hear the truth about it. We just heard a wonderful talk here on the truth. To be more informed yourselves and make your own educated decisions, I think is something that I cherish greatly. I cherish that greatly in my patients who come see me, who've done their best to try to get informed, albeit, as you know, there's a lot of information out there, and how do you sift through it? So to come to this sort of event, to hear the various speakers, the other panelists, I also congratulate them for being here today, and to become more informed yourself, I think that's a wonderful thing. Now, we've heard this morning already about some barriers that have to do with why men do not even seek doctor evaluations. And perhaps what's the biggest one of all? Well, the fear of losing your sexual function, of course.
Can I get you to...
Oh, get shorter.
A little bit.
Get shorter, I guess.
Or just take it out.
Is that a little better?
That's better.
Wonderful. So, the greatest fear here is that you may lose your sexual function if you proceed with an intervention for prostate cancer. So with that thought in mind, I'd like to let you know that I think we do want to deal with this subject head on, that we do want to address it, and let you know that we are aware of it, we're sensitive to the matter, and we do want to make sure that we preserve this function and help men know that they can move forward with managing their prostate cancer and preserve this very important element of their life. So let's begin with the slides. Okay, there we go. All right, so my talk is entitled The Truth About Erections. And I'd like to begin actually with a true email from one of my patients. This is a few years ago. But I think this does, capture what many of us think about, men who are undergoing treatment. This gentleman underwent a radical prostatectomy, and he goes on to say, it's been about 7 weeks since you removed my prostate. This was July of 2002. And it would be nice if I could tell you briefly how I'm doing with the healing process. We have an office visit scheduled in November, which is about 6 weeks away. His continence control is very good. He's very pleased that the surgery went so well, but he's concerned about the sexual matter, and this is important to him, to feeling good about himself as a healthy person. Now, he's a well-read gentleman, and he goes on to say, as for tumescence, there is almost none, so he's really talking doctor language here. He's very well-informed. Tumescence refers to getting some level of an erection response. I'm 53. We consider that young, I think, these days. And before surgery, he had been using some Viagra. But he's going on to try it again, and it's not been so helpful for him at this early stages of his surgery. Again, this is only 6 weeks or so after the operation. According to the medical literature, the reinnervation phase, and he's referring there to the nerves that we've learned a lot about that have to do with how erections are regulated. Again, very well-informed patient here. And he's familiar with the idea that these nerves can be traumatized even with the very best surgery, and that they do have to recover. And he does have an awareness that it may take as much as 18 months, if not longer, for some men to have this reinnervation occur. That's great, but sooner rather than later, I'd like to resume sexual functioning much as before. And he goes on to make remarks here as to just how it's important to him to recover function, resume function, and wonders what else can be done. So I think this illustrates, this is an actual email of where we are with this surgery nowadays. You heard from Dr. Kadedu that we have certainly improved upon the surgery. I think that expert surgeons achieve great outcomes. This is an example of many of my patients. I do a low midline abdominal incision to do this surgery. Many of them do very well. They're back at work rapidly. Their continence is good. Their erections and their sexual functions are matters of great importance. And it's almost like there's a disconnect, even while you talk to the patients, because while they recover these other areas of function, it's kind of hard to accept, well, if I'm recovering well over here, then I must not recover here with this, because they should be right along with this. It's a hard discussion to have, to kind of go over that in many men, potentially their recovery will occur in time. But we still need to be proactive about this, discuss it, and possibly think about innovative ways to recover function. So what I want to do with this talk moving forward is to tell you about where we are with managing erectile dysfunction following radical prostatectomy. Use that as a paradigm, although I think this is important for any intervention for prostate cancer that can impact on sexual function, be it radiation, hormone therapy, and so forth. But also let you know where we're going, because we don't want to just paint a doom and gloom picture here. Rather, we want to recognize the problem and think about how we can improve upon it. And I'm going to give you a little sense of where we're going scientifically. These slides are a little funky. So let me just mention here again the description of the problem, talk to you about some of the prostate cancer interventions. All right, there we go. And then just talk about managing erectile dysfunction. There were questions earlier about what are the options. And so I will go through with you, again from a urologist perspective, what options we have and what really works. What's the truth about the management that we have? Now, in terms of male sexual function, I just put up here just the truth about understanding male sexual function. Us urologists were blameworthy in the past for perhaps just using words that were not specific enough. When we talk about impotence, what are we talking about? And it turns out that there are different elements of the sexual response cycle that have to do with erections, that has to do with orgasm, satisfaction, and even libido, which is sexual desire. So being more precise, we've used this term now, erectile dysfunction, in the past 15 years because we think it may be more precise and certainly less pejorative than the term impotence by and large, which has these connotations of helplessness, weakness, powerlessness, and so forth. So I think that we want to be specific about what we're identifying as a problem and what we're trying to treat. All of these elements could have impact with treatments for prostate cancer. Erectile dysfunction refers to the inability to attain and maintain erections that would be useful for satisfactory sexual intercourse, almost as a definition. So I just want to make sure that we're talking the same words here. Are we talking about erections? Are we talking about libido? Are we talking about orgasm and so forth? So let's be precise about what we're talking about, because that way at least we can approach the problem more correctly. Now, with the various treatments that are offered, this just makes the point that with surgery, we think that there's nerve injury that occurs, vascular injury, blood vessels that course in the pelvis. The prostate is in a very precarious place in the body. In the deep pelvis, where there are a lot of structures there that have to do with a lot of different functions, including erections, bowel function, urinary function, as others. Radiation potentially can damage some of the similar structures that are critical for the erection response. Androgen deprivation therapy, ADT, refers to hormone suppression that we often use, sometimes in combinations with these therapies, radiation primarily, and many may fail early treatments and they may have to go on and receive additional treatment that may be in the way of hormonal therapy. And of course, there are many who may have advanced disease when first presenting, and they're not candidates for any sort of local therapy such as surgery or radiation, and they may have to be considered for advanced therapies that do have some of these potential risks. So again, just helping your awareness that all interventions have potential risks. One of the conversations I have with many patients is, well, I don't want surgery because I want to avoid any risk of sexual dysfunction, so radiation is a good way to go. Well, let's talk the truth. There are some potential risks with any form of intervention, including radiation, and that may have to do a lot with just the position of the prostate, where there are so many critical structures that are important for erections that could be impinged upon irrespective of the intervention. Now, I list on this slide just what are some of the sexual dysfunctions that we'll see. Again, just to be forthright about all of this, because I've had patients that come up to me and ask me about various little questions. My penis is deformed, Dr. Burnett. I think I'm having a little urine loss when I have orgasm. So we recognize now that there may be a whole host of sexual dysfunctions that could relate to the radical prostatectomy, as well as for other interventions. This ranges from diminished libido. Men may change their sense of sexual desire or interest in sexual activity. Reports are out there that range between 10 and 80% of patients undergoing therapy experiencing these kinds of consequences. Erectile dysfunction, almost to a level that it's expected that some men may never get function back. In fact, in the past, historically, it was thought that if you underwent a radical prostatectomy, you knew universally that your function was going to be gone in terms of getting erections. Erectile deformity, we talk about that. In fact, I even put that on my consent forms with patients going to surgery because I want them to know the truth, that there may be some incidents of changes just in the structure of the penis from the lack of circulation, the lack of activity with erections, some changes within the tissue where we feel some sort of minor scarring or fibrosis. This can occur, and we're aware of this, we accept this, and we have to think about how we're going to address this. But again, we should be forthright about talking about this. Ejaculatory disorders, well, if you have your prostate removed, you remove the prostate seminal vesicles and the structures that lead to really fluid coming out. So all men should be informed that you will have a change in what goes on when you have an ejaculatory response. You have the sensation of orgasm, but no fluid really comes out after a prostatectomy. That's the truth. Let's be aware of that. Climacteria refers to when you have sexual response and an ejaculatory response and may lose a little urine at the time. What happens with normal sexual function in men is that the area deep inside the pelvis where the ejaculation occurs, some of that area relaxes to allow some of the seminal fluid and ejaculate to come out, and that may also mean relaxation of some of the bladder neck area, and therefore some of the urine may come out following a prostatectomy. Some men have discussed various changes in their orgasm sensations, and you see the rates that are up there, and even some men who believe that there may be changes in the presence of the orgasm altogether. So again, I just put this out here because there are things that occur. And this, of course, doesn't mean that you don't address the problem. I had one patient one time, he approached me and said, Dr. Burnett, I've hemmed and hawed about this surgery for about 3 months, and I've come to realize I better move forward with surgery because the ultimate form of erectile dysfunction is death. So I guess I better move forward. So again, it's not a matter of trying to paint a bad picture, but let's talk about it and let's talk about what we think we can do about it. Now, this again is kind of a medical slide, but I think maybe some of the facts there might be relevant to some of the audience. We do know that surgery today does offer great long-term rates of cancer control. We have seen in our literature more studies that suggest that carefully followed patients that we are impacting on outcomes. Men are going to survive if they get this surgery done. This seems like an automatic thing to say, but in our medical literature, we really want to make sure that we're not intervening with patients who may otherwise have a longevity that would not be impacted by the surgery. And I think that the answer is that we do know that we are doing the right thing for many men who really have great longevity ahead of them, that we are going to save lives, and we are saving lives. Now, erectile dysfunction is a known complication of the surgery. Historically, as I mentioned, if you underwent the surgery in the past, it was all but certain that your erections were gone for life. And I think we've improved upon that. And if you look at the literature today, at least in major centers in which there are highly experienced surgeons who are doing the surgery, erectile dysfunction rates are not universal, not 100%. It may be in the range of 15 to 40%, although I can tell you there's a great deal of variability in the reporting, and part of the problem is that many of the reports do not account for a lot of variables, which I'll talk about here momentarily, that have led to just a wide range of what you'll read out there. It depends on what a person's preoperative function is, the extent of their cancer, how much the extent of the excision or the surgical resection had to be, all these factors that oftentimes are not really plainly stated, but be aware these things can impact upon what a surgeon or any other specialist may say. What's really the other circumstances that are related to what kind of quote you're telling me, that sort of thing. This reports then those men who are preoperatively functional, have the opportunity for what we call nerve-sparing prostatectomy, which I'll talk about in a moment, and really are favored then to have the opportunity to recover erections, that we see this kind of recovery. And I mentioned earlier, other comorbidities are largely controlled today, and I can tell you, having done about 2,000 radical, well, more than that by last count, but just being a surgeon for a long, long time, I can tell you when doing the surgery 10 years ago, it was not uncommon that patients would experience incontinence for a better part of a year. Their stamina may be poor for 6 to 12 months. Irrespective of the surgery, because of improved proficiency of the surgeons, anesthesia techniques, and so forth, many patients will do extremely well, just like the patient that you saw with the email. And because these other aspects of their recovery are so much more well controlled, sexual function does, at this point in my mind, represent perhaps the last frontier in how we need to improve upon outcomes from following treatments for prostate cancer. Now, you saw from Dr. Kadadi's presentation what the surgery kind of looks like. Here's another representation, a cartoon, if you will. This is a side view of a man's pelvis, the bladder, the prostate. And what I'm trying to show you here is where these nerves course. If we take the prostate out, okay, and you can see the prostate was here, and then in this view, which is kind of an oblique view in the pelvis, we remove the prostate. We actually then reconstruct the bladder, almost creating kind of a funnel, and then reconnecting it to the urethral stump, the urethra there, and attempt to preserve all of this nerve tissue that historically was just widely taken out, and really the precision of the surgery wasn't very good. And we're actually much better about this thanks to the pioneering efforts of Dr. Patrick Walsh at Johns Hopkins, who described the nerve-sparing technique back in 1983, and then surgeons throughout the world apply this when it's appropriate. Now, if a man actually has more extensive disease, then the decision has to be, you're saving that man's life. And if that means that you have to go more broadly to excise some of the surrounding nerve tissue that governs how erections occur, well, that decision has to be made, and then we discuss about other options for managing erectile dysfunction afterwards. So this just hopefully gives you a sense of those who may be less familiar. What are we doing there? Well, the surgery is much more detailed than that. But get a sense here that that's how we go about the surgery in the pelvis with the reconstruction that's involved. Now, there are many factors that impact on sexual function quotes. I mentioned these briefly already. We know that the surgery itself can impact in terms of nerve injury, maybe some blood vessels that course around the prostate that also supports circulation to the penis. There may be psychosocial factors, depression, anxiety, relationship circumstances. There are certainly situations where the dynamics of a relationship following the operation and the recovery can be a factor. I've had some patients whose spouses say, honey, we're not going to even get involved with that kind of thing. I just want you alive. And that's understandable. But then, understand that there can be some challenges there with regard to how a person might recover function. And then, to make the point, health comorbidities in terms of other factors that impact on function. One of the things that I think is very important to recognize is that many men may have pre-existent risk factors, cardiovascular disease, diabetes, we're hearing about the metabolic syndrome, all these other kinds of things, that a patient may have been acceptably functional prior to the surgery, but really he wasn't functioning like he was, in a younger stage of his lifetime. And perhaps going forward with surgery then may have just been a little bit of something that tipped it over just a little bit more. And we need to recognize some of these variables that can impact on function. And people need to be truthful and understand that these are factors. And we've already heard about age. There's no question. The older you are, the nerves tend to recover much more slowly. Your recovery itself is much more slow. So we need to recognize this variable as well. Now, what about management? Management in general can be just counsel patients about what are some of the potential risks. Testosterone replacement has been discussed. That's a whole other discussion in and of itself. Testosterone is male hormones. And there's a lot of controversy surrounding that topic, particularly for the matter of men who may feel their libido changes, their sex drive changes. Should we replace them with testosterone? Controversial. Maybe in the carefully selected patients. But the concern, frankly, is this. Prostate cancer cells thrive on the fuel called androgens. And so you want to be very careful about thinking about, do you really want to have this sort of intervention initiated if there is a sense that we want to improve upon this concern of sexual dysfunction. Very clearly, patients have to be counseled about this, and we have to evaluate hormone levels and make very critical decisions about who we don't want to possibly risk causing a progression or recurrence of disease. And then erectile dysfunction management specifically for erection disorders, and let me go through that here momentarily. Know that in this field of sexual medicine now, current times, is that we do respect the fact that patients play an integral role in how we decide about treatments. We use this term patient goal-directed therapy for sexual management by and large. Part of that has arisen because we have evolved now to have a whole host of therapies, much better than we had 25 years ago. In that era of time, we only had penile prostheses, and we really felt it was critical to work patients up very thoroughly, be very careful about who wanted to move forward with this sort of surgical intervention to put a device in the penis to be used for sexual activity. Now we have a range of options, including lesser invasive treatments, which I'll show you here momentarily, and therefore patients can help us decide what makes sense for them, because everything has its advantages and disadvantages, and I'll touch on that here in a moment. Management of erectile dysfunction in general, I think, is evolving to where we do recognize that there may be other risk factors that patients can work on to improve upon their functioning. This applies to men following radical prostatectomy with erectile dysfunction, but also erectile dysfunction in various other clinical scenarios. And so we are certainly recognizing that men who are more physically fit, who are more active, who reduce weight, cut out cigarette smoking, get some of the other health issues perhaps under control, that we're seeing more and more data that does suggest that you can improve upon your overall sexual function and erections specifically. So keep that in mind. That's really a strategy that I think we are aiming more and more for, that the patient has to help us with some level of responsibility with recovering sexual function. I'm going to talk about the stepwise approach for decision making. As mentioned on the prior slide, that we typically moved from the least invasive option to the more invasive options in kind of a sequential way by and large, thinking that the lesser invasive options are really reversible, that you haven't done anything that commits to a patient to a certain way that they can't decide on something else. And so therefore, that's kind of the strategy that we've tended to use more and more these days. And I also mentioned that many patients can benefit with psychosexual therapy because of just the impact of the disease, recovering function. And I think many times we just want to see a quick fix with a pill or something like that. Even as a urologist, and I try not to be a uropsychiatrist, but I think there's a role for another specialist to be involved to support that couple. I think that's very important to recognize. So don't dismiss this, and this doesn't mean that you're any less of a person or any other negative feature to pursue this sort of thing, but I think it may be important to recovering function. Now this slide nicely tells you what are our options for dealing with erectile dysfunction in a proactive way in terms of true interventions that we have. These interventions range from lesser invasive options to more invasive options. Oral PDE5 inhibitors that you're familiar with, Viagra, Levitra, and Cialis, they represent first-line therapy. They tend to be more effective if you spare nerves, not really effective if you don't spare nerves. And they do require that these nitric oxide producing nerves, a chemical here that we've learned now does serve as a very important neurotransmitter, governs how these nerves fire and how they work, that these need to be preserved. But at the same time, if they're traumatized, even with the most delicate surgery, those nerves not divided, not cut, just dissecting the prostate out, but they get traumatized, these nerves can be traumatized for as much as 2 years for some gentlemen. And therefore, these medications, to answer a question, why are they not effective early on following radical prostatectomy? The answer is that if these nerves are dormant, then they may not actually lead to the release of the chemical to which the medication works with that release to bring about the response. This is how these drugs work fundamentally. So they require some level of function of these nerves to which the medication augments the response. So many men may find that these medications do not work early in their recovery. They may have to recover over some time, getting maybe partial erections, to which the medications, when used properly, may augment that a little bit. And if they're a little further along, well, it may augment it better. But if they're still pretty much running in neutral, what's something times zero? Still kind of zero, I guess. So just be aware of just how I think we recognize how these medications work in this setting. Various other alternatives, local therapies are second line. This is intraurethral medications like Muse, if you've heard of that, medicated urethral system for erection. This involves a suppository that's put inside the urethra, the urine channel, and a little bit of medication comes out like a rice pellet. You remove the device, massage the penis, and the medication is expected to be absorbed in the penis and produce an erectile response. It requires in-office instruction. Efficacy, though, is not as reliable as other options. Injections, okay, this is something that may strike fear in some, putting a needle in your penis. And then, believe me, I don't think any of us surgeons take a lot of delight in any of this, but as a therapy, this is how we deliver medications like Viagra. These actually preceded these newer innovations, but these are vasoactive drugs that cause the erectile tissue to respond, mimicking the chemicals that would be released from your own nerves to cause the erectile tissue to respond with engorgement to create the erection response. And these are highly successful. Again, it requires a training in the clinic setting to make sure patients do this safely so they don't do some harm to themselves, over-inject or inject in the wrong place and so forth. Vacuum constriction devices are another second-line option. Okay, this refers to a cylinder that's brought over the penis, brought down to the penis-scrotal junction, the junction between the penis and the scrotum, creating a seal. And then with a motorized pump or hand-driven pump, you create a vacuum effect, and blood is brought into the penis. A constriction band is released from the base of the cylinder, and this is then released to the base of the penis that holds that engorged blood in the penis. You remove the device, have that constriction band in place, and then you can use this erection-like state for sexual activity. So this is another alternative, highly successful. But instruction again is useful there. Now, let me just take a moment to mention all of these therapies require some planning. They require some manner of, honey, time out for a minute, that sort of thing. And therefore, they're challenging in some instances to use because they don't afford the convenience, spontaneity, and so forth that many patients do value. Not to mention, perhaps, all the mechanics and machinations that are involved with using these therapies. But nonetheless, they are successful, and you can see what the rates are there. Penile implants refers to penile prosthesis surgery. I mentioned that earlier. This is a surgery in which we put devices inside the penis, where a man then undergoes an operation, and there are components of the device that we put inside the penis and a portion in the scrotum, a portion up inside the abdomen area. It requires very skilled surgeons who do a lot of these operations, and it's all concealable. Nothing is protruding from the body. When using these devices, you pump it up, as they said, because you're transferring fluid from the reservoir portion to the cylinders, and then you get an erection state there. It creates rigidity for the penis. And everything else about the penis is intact in terms of penile sensations, sensitivity, erogenous sensation, and so forth, and ability then to engage in sexual activity. And in fact, this probably enjoys the highest satisfaction rate of all interventions because it allows this more rapid opportunity for sexual activity, but certainly preserves various other functions. So that's something that's appealed to some, but others feel like, well, I don't want to have another surgery. I don't want to have to deal with some of the issues there. And there may be some small risks there, too, of device malfunction, infection, need for revision of the operation, things of that sort, which really are very, very infrequent, particularly, again, in experienced surgeons' hands, but there's still real risk factors with that. So again, advantages, disadvantages of different options that are out there currently. And that's why we're very sensitive to the matter. So, by way of conclusion, sexual dysfunction does occur in the management of prostate cancer. It's a common problem. I think we should not shy away from it. The term earlier today was take it head on. And sorry for the pun, but I guess that was used before me. But certainly try to address the problem. Certainly counsel patients correctly. Let them know that we're keen about doing our very best operation to make sure that we do our job in trying to preserve nerves where it's appropriate to give them the best opportunity for recovery of function. And then on the heels of that, think about management options. And the management options include all the different opportunities that I talked about with the prior slide. And be aware that we are moving forward here to try and address this problem as best as we can. We're trying to understand what are the real scientific basis behind the disorder and think about therapies that we think can improve upon our outcomes. So I will stop there, and I do appreciate your attention.